Welcome to ACC 2026 in New Orleans. This is Bala Pushparaji, second-year cardiology fellow at Metro Health, Case Western Reserve University in Cleveland. I have here with us Dr. Ajay Kirtane, world-renowned interventional cardiologist and director of the interventional lab at Columbia, and also professor of medicine at the Columbia University Irving Medical Center. Dr. Kirtane, thank you for joining us. It's a pleasure to have you here.
Oh, thanks so much to you and everybody for listening.
So Dr. Kirtane, as you guys already know, is presenting on his late-breaking clinical trial, All Rise, tomorrow morning. And so, he's happy to, just give us a preview of the trial today. So Dr. Kirtane, can you give us a preview of the trial?
Yeah, absolutely. I think that first, I just want to say that while I'm presenting for fellows, it's really important to recognize that there's a team behind all of this. So Bill Fearon's a PI. He's actually going to be the first author of the paper that's going to come out. There's a whole team of steering committee and everything. And many people always ask how it gets created. And that's the way it gets created, is with the team. So it's not about me or anything like that. The idea here with this trial is I think everybody knows that coronary physiologic testing in the cath lab is a good thing. It's class 1A in the evidence, actually high value because you put in less stents. But the real issue is that people just don't do it that often. And some of it has to do with workflow. We often say people have clinical inertia. Yeah, that's true. But sometimes when the workflow requires taking a guiding catheter out, opening the wire, putting it past the lesion, and all the steps that it takes, plus the small risk for a patient, you can understand why it's not done. And so there are other ways of doing it. And one way of doing it is to take the angiograms, feed it into a computer, and come up with a 3D model that the doctor then looks at, says, is this okay or not, and makes a correction if they need to. And then it gives you values of FFR along the coronary tree. And those numbers correspond really well with the wire-based physiology. But what we haven't tested or proven to date is whether making decisions based upon those numbers versus the wire is associated with similar clinical outcomes. So it may make sense to do something, but as you know through your fellowship, unless you generate the evidence, it's hard to prove it and hang your hat on it. And so that's what we tried to do in this trial.
That's fair enough. So I haven't heard of AngioFFR until recently the provision trial came out, and now the All Rise trial as well. Can you give us a preview again of the AngioFFR technology, and how long has it been there for?
Yeah, so this is a technology from CathWorks. It's called FFR Angio, and what it does is it takes the angiogram, and it's interesting. In the first version of this, where we were in one of the original trials called Fast FFR, and Bill Fearon is the lead author on that. In that iteration of things, you had to trace every single vessel, and it took time. This thing now, because the computer is smart and there's AI involved, et cetera, knows what the right coronary artery is, knows what the left is, can start tracing things. It can leave off the third septal because it's not relevant. Like things like that are really in the system, and because it's software, it iterates pretty quickly. So the idea behind it is that by doing those tracing, and again, verifying them from a physician side, you can then derive throughout the coronary tree where the pressure drops are. And that allows you to come up with a treatment plan. And so that's basically the technology. As I said, though, it needed to be compared against a wire.
Oh, fair enough. So, let's say you compare AngioFFR with, the wire technology. What benefits do you think the technology has over?
So what's always been interesting is that it seems like it's easy to just, take off your gloves, go do the thing on the console, not have to instrument the patient, et cetera. But there are hardcore FFR folks out there who say, well, I can do the wire faster, right? I can just do this faster. But it turns out that that's something you can study. And so randomization is so essential to these things. And so in this trial, because we randomized 1,900 patients, you could do FFR angio versus a wire and not just measure the clinical outcomes, but how long it took to get the physiology, how long the procedure took, fluoroscopy time, contrast, volume, and all of those things we measured in this trial so as to be able to definitively answer the folks who say, oh no, I can do it faster one way or the other.
That's wonderful. Okay, I'm very curious to hear about the findings of the All Rise trial. So give us a brief summary of the study design and what outcomes you looked at, the endpoints.
So look, as I said, randomization is the key here. And what we basically did is we took patients in the cath lab. The investigators had to feel that these merited physiologic assessments of 50 to 90% lesions, predominantly stable syndromes, randomly assigned to FFR angio versus the wire. And with the wire, they could do adenosine and do FFR. They could do non-hyperemic index, and we stratified the randomization that way. We then followed patients and measured the procedural outcomes, followed them to a year to look at the causative MACE. You should know as fellows that MACE can differ in various clinical trials. In this one, it's all-cause death, myocardial infarction, or clinically indicated revascularization. So not just coming back to the cath lab, they needed to have a clinical reason for it. And that's what we measured. And I've been putting you in suspense this whole time, so I can give you the results under embargo. But basically what we showed is that FFR angio was not inferior to the pressure wire. In fact, if you look at the Kaplan-Meier curves, the outcomes are virtually superimposable. But importantly, when we looked at the procedural outcomes, it took less time to calculate it with the computer. And remember, that's without any of the procedural manipulation that I talked about before. No anticoagulation, no adenosine or anything like that. The overall procedure time was less, despite there being a slightly higher rate of PCI in the FFR angio arm. Contrast volume was less, and similarly, fluoroscopy time was less. So basically, the take home is that number one, there's no penalty. The clinical outcomes are identical at a year. And number two, the workflow improvements should support this. So I think for me, what that really means is I hope that people will start doing more physiology, because it's class 1A in the guidelines. You do less unnecessary stents that way, but because it's underutilized, we need to do something better. And I hope that we've established that you can with this technology.
That's wonderful. That's I just remember one of my interventional attendings. He's one of those people who never liked the FFR wire. I'm sure he probably enjoys the AngioFFR technology being out there.
Maybe. Sometimes people need to be convinced. And the point is that traditionally speaking, the way we have done PCI in the cath lab is we look at the angiogram. As you get older, like me, you maybe squint a little bit the angiogram and you say, well, that's like a 70, so I'm going to treat it. And that's a 40, I'm not going to treat it. But we need some objective evidence, and the wire gives you that. So I'm a big believer in physiology, but we actually have this in our cath lab. And once we started using it, and I seemed to be convinced that it made sense, then I actually have rarely used wires now, except for things like microvascular flow testing. But I was always nervous in the back of my mind that the clinical outcomes haven't been proven. So this makes sense. It's faster. And yes, I can move through my case, but I needed to prove the clinical outcomes were equivalent. And essentially that's what we did. Remember, non-inferiority does not mean equivalence, but we powered this pretty well. It's 1,900 patients, and the outcomes are virtually identical at a year. So I think for the most part, it seems like this is something that you can definitely use in your clinical practice. There are some caveats. Patients with prior CABG, patients for whom CABG was being considered, were not included. The majority of patients are stable, but in general, it's pretty reassuring. And I think that's good news for patients and physicians.
That's wonderful. Right. So based on your experience with the technology, do you see any hurdles in nationwide adaptation?
Yeah, I think like anything, you got to get used to it. And there are times when you'll want to, redraw the line. The biggest hurdle is you have to take a good angiogram. And so for fellows, that is super important. Right. Learn how to do a good cath, because if it's garbage in with AI, it's going to be garbage out.
That's good to know.
So take good angiography, make sure you lay out the lesion in multiple views. If it's an eccentric lesion and you just completely overlap everything, no technology is going to save you. So you got to do a good job in the lab. And, but if you do, and you have an open mind to being able to figure out how to use these things, then it's a pretty good tool. I also think one nice thing about it is that it's not a black box. It's not like AI just spits out a response and you don't know what it's doing. You can, and you have to review the tracing, make sure it makes sense, and then run it, which means that we're not going to supplant any of us anytime soon. It's just sort of an adjunct to what we do and a workflow enhancement.
That's wonderful. That's wonderful. So, everyone's, waiting with bated breath, I think, to hear from you tomorrow morning. So besides that, Dr. Kirtane, I wanted to ask you in general, I'm a fellow who's interested in going to interventional cardiology. So for budding ICs, the field is changing very fast. Correct me if I'm wrong, our field is very dependent on tools and technologies. So how does someone as a young fellow get, if want to innovate, right? How do you get into industry and start working with these people?
Well, look, I think the first thing is the tools and technologies are part of what we do, but the heart of an interventional cardiologist is actually not in your hands. It's actually in your brain. And you need to be able to figure out how to apply these tools to patients in a way that is not unscrupulous, but yet, you're doing it for the right reason to be able to affect the patient outcomes. But yeah, you do have to interface with industry, but it's also important that you're the patient advocate. And oftentimes industry is going to be aligned with you in that way, but at some point they have a fiduciary responsibility to make sales and things like that. They know that, but they know also you're a good doctor, and they'll respect you the most if you practice, clear, uncontroversial, patient-oriented medicine. I've actually, I'd say, made my career out of trying to be thoughtful and trying to push back appropriately. And I've always found that maybe you have some short-term losses that way, but in the long run, that's how you build a reputation. So I personally think that don't feel like industry is the enemy, but the folks that just schmooze all the time, there's a slippery slope there. So you do have to always retain your patient-oriented focus. And when that alignment works, like in this particular case, it's a great working relationship, because I can't program the software and I can't, make the consoles and all that other stuff. But I can say, look, we really need to have this, or no, I'm not going to compromise here. We need a randomized trial. And if you push hard enough, and obviously I'm very fortunate I was in the right place that I could push in that way. And there are a lot of people who let me do this. So Marty Leon, one of my mentors, he allowed me to be in the situation, but then you can do really good things. So I guess that's the message I'd.
No, I think you're right. I mean, in the beginning you said it's all teamwork, and that's exactly what you're telling us. I have one final question for you. So, if you had to go back in time and, you're an interventional fellow, is there any advice you would give yourself?
Look, I think it mainly just be keep using your head. It's not just about the hands in the cath lab and all of that. I also think keep it open mind, because when I trained, this tells you how old I am, structural heart disease didn't exist. It was mainly balloon mitral valvuloplasty for rheumatic stenosis. TAVR hadn't come about. None of that stuff came about. And I'll confess, I didn't really care too much about my echo rotation and TEs and things like that. Obviously, had I anticipated what's going on, I would have been doing a ton of echo and things of that like. So just keep a really open mind, get a broad-based education. CT is something, for instance, you need to get a lot of training in. As an interventionalist, I'm a firm believer that you need to know how to read CTs, because that's where everything's moving. But just keep the love of learning there. Training, it can be long and hard. It's a lot of years. And you guys have been dealing with a lot. You've dealt with the pandemic, and we just dealt with a nursing strike and all kinds of craziness. But I think at the fundamental level, medicine's fun. It's really interesting. The science and cardiology changes all the time, and that's new. And there's no substitute for the patient care experience. All my friends who, when they came out, same age as me, who went into finance and all that other stuff, they're jealous of the patient interaction experience that I have now, and they're looking for it in other ways in their career through philanthropy and everything else like that. They probably have a lot more money than I do, but I maybe think I'm a little bit happier.
That's wonderful. That's a great message for all fellows out there, I think. So Dr. Kirtane, thanks again for joining us for the FITSCO initiative. We all look forward to hearing you again tomorrow morning. And to the audience, thanks again for joining us in ACC 2026 in New Orleans.
Well, thanks so much for having me. And he told me he doesn't do this very often, but you're a pro, so I really appreciate it.
Kind words from you.
No, I think, look, the fellows always impress me with stuff they're able to do, so I'm not that surprised.
Thank you again.